Most important muscle in the lower back, one that you always have to address with any type of lower back condition, the iliopsoas. I'm going to start with our strength testing here, and make sure that we abduct, externally rotate, and flex, and that's the position right there. We're going to contact the opposite iliac crest for stability, to hold it down, hold it up, and there is our test straight down there. And he's nice and strong in there. With iliacus portion, you're going to bring the leg in closer toward midline. Keep it up at the same level. Hold that up. Again, supporting and pushing down. And he's quite strong in that area. So for the iliopsoas, for the psoas portion of iliopsoas, we're going to start with the leg externally rotated fully and flexed. We're going to come in just near the iliac crest, right on the psoas, and what he's going to do is we're going to have the patient internally rotate the leg this way, and keeping the knee bent, bring the leg down. So here we go. Breathing and turning slowly. Keep it down, bring it down. Very nice. Now, if bringing it below the table elongates the muscle to the point where it bounces up, then only bring it to the level of the table. But if you can bring it down below the table, beautiful. Keep working with it. And sometimes you might give a little bit of a rebound on that muscle. Now, with this muscle, you can go all the way up. Don't forget, it goes to T12. So you can go right into the spine. Let's just turn on your side a little bit. And you can do your PDM all the way from the spine all the way down. So you may want to work your way up directly into the L1-2 region. Let's just give an example of that. Here's way up towards L1-2. We're going to go deep, deep, deep breathing and turning. Nice. And he's coming down. For iliacus, we're not going to externally rotate quite as much, and we're going to actually just take a contact in the iliac fossa. You can feel the iliacus. That's the only difference. Sorry about that. We just hit one little spot. We had a nice reduction there. And turning and down. We're going to go into the fossa, breathing and turning. Beautiful, 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 beautiful reduction there. Very nice. And here we have a psoas TL. We can do it either with this thumb, or we can switch and do it with this thumb, holding onto the leg, whichever way is more convenient for you. Breathing in and pulling up fairly hard. And let it go. We don't even have to straighten the leg. We can keep the knee bent, breathing, and coming up. And let it drop. Very, very nice. That just opens up beautifully in there. We can go up higher. This can be iliopsoas, iliacus, and a psoas procedure. If you want to modify that a little bit, we can actually hold on with our knees here, this way, breathing, and pushing up with the leg, breathing, and pushing up with the leg. Beautiful. And there you have it. Very important. Another great iliopsoas TL procedure, one that I use a lot on athletes, is the procedure where you have the patient on their side, contact point with the thumb this way. Actually, we have to get him more on his side. Let's go more on your side here. Way up there on the side. And what he's going to do is he's going to press his knee in towards me as he breathes out fairly hard. Breathing and go. You can use your chest as resistance and let it drop. Breathing and going. And let it drop. That's just a beautiful procedure for iliopsoas TL. Okay, great. So we're on to gluteus maximus. We're going to do strength test. We all know what this one is. Let's lift this leg up here, straight up in the air. Hold it up, stabilize, and pressing straight down. So for gluteus maximus TS, we're going to do two procedures. One where we have the patient prone and we lift up the leg in that start position and then simply bring the knee down. And then another one, we're going to put them on the side position if they're having problems with the sacroiliac joint, which prevents them from being able to hyperextend the pelvis. So I'm going to actually hold it up here like this. We're going to actually bring it out a little bit. Just relax. Bring it out here a little bit. He's going to come down and in. There it goes. See how that dropped in? Just let it go. Let it drop. Let it go. Let me have it. Let it go. Let that go loose. That's it. Breathing in and out. Coming down and in. Again. Let it go loose. Down and in. Very nice. And again, breathing in. Down and in. Very nice. Can't get over how this looks like the Estonian flag here. Okay, we're going to go on to the side position now. And what we're doing here with this one, well, we can stay on that side, even though we're switching sides for a minute. We've been mainly doing right side, but we're going to do left because it's convenient here. What you're going to do is do a contact again, and don't forget gluteus maximus is multi-pennate, so your PDM is going to be a little bit of a torsional PDM on that muscle. What he's going to do is he's just simply going to flex his leg and bring the leg up this way and just slide it without contracting these adductors. So you're just going to let that lat relax. Just let it relax and slide on the other leg. That's basically what you're going to do. Let these two knees go together. Okay, I know why they're not going together, because his muscles are so big. Okay, so here we go. Breathing and coming forward. Very nice. And we're doing a bit of a multi-pennate. Now I'll turn him over slowly just to show you the PDM that we do on that. Let's turn over on that one. Now we'll get over to that right side again. Let's go over on the other side. And from here, you can at least watch the PDM breathing in. You know what's happening with the leg. And I'm kind of turning it a little bit. Breathing and turning it. There, and coming down and through this way. Breathing, and again, there it is. You just got to come forward a little more. Give me a little more motion there. Breathe. Yeah, there we got it. Okay, there you have it. Here we are with a TL for gluteus maximus, and talking about Maximus, Maximilian just told us that this is his tightest muscle. So he's enjoying this right now. Breathing in and pushing toward me. We're going to really give this a good, and letting it drop. Let it go. Ooh, very nice. Breathing and going. And letting it drop. Breathing. And again. Now you can use an instrument on this if you want. You can use your fist. You can use heel palm, whatever's comfortable. Breathing, and again. And let it drop. That's pretty simple. Now, we do have one more way of doing that TL procedure. And the way that we do that is we can either come from this side and come through here, contacting here, and having the patient push with his knee towards me. Let it go. Or we can walk over to the other side of the patient, have him raise up, and you can use your body. You can get in here this way and pushing and letting it go. And you can come in underneath and use the radius to actually dig in there. Breathing and go. You can actually turn the radius and let it go. There you have it. Lateral rotators. Here we are. We're going to internally rotate. He's going to hold his leg like this. I'm going to attempt to pull back. And that's nice and strong. If it was weak, of course, it would just go that way. So here we are doing the TS procedure on the lateral rotators. You can use a thumb like this. You can use a fist and twist a little bit in there, whatever you want. Usually I'll support the thumb this way. Breathing and coming, nice and easy. Breathing and coming slowly, very nice, very nice. Or fist, breathing, and I'll just lose a little bit of a twist. And if you want to, you could come from the other side. I'd switch around sides, and I can come from the opposite side of the body and use the heel palm. Very, very nice. Breathing and coming over. Good. Again, and just coming down and through the lateral rotators in this direction. The deep lateral rotators, we're going to just do the opposite for TL. We're going to support the knee with your knee. He's going to come in this way. You may even want to support the knee, either side of the knee this way. Was this the side you had the meniscus problem? Mm-hmm. Okay, so you're going to pretend to push real hard. I don't want him to push super hard. You always want to know if the patient has a knee problem. You always got to check that. Breathing, and you're just going to pretend to push real hard. Don't push too hard. Okay, but as always, you're going to use about 80% maximum effort. And letting it go. There you have your TL for your deep lateral rotators. Gluteus medius can be done in the, and minimus can be done in the side posture as well as supine. For the purposes of this video, we're going to do it in the supine position. So we're going to distinguish, first of all, gluteus medius, generally speaking. We're just going to put the leg out, hold it there for me. I'm going to try and pull it in. Now if we want the posterior fibers, we're going to have him turn his foot out, and I'm going to pull it in. If we want the anterior fibers, we're going to have him turn his foot in, and I'm going to have it pull in. If we want gluteus minimus, we're going to have to lift the leg about 15 degrees. We're going to turn the foot in a bit for anterior. We're going to turn the foot out a bit for posterior. And actually, that one, oh, he's got a gluteus minimus posterior fiber weakness. That's the first weakness we found on you today. So there you have your strength for gluteus medius and minimus. We're going to be doing the medial rotators now, and this is mainly gluteus minimus in here. So he's going to just simply externally rotate the leg. Breathing in, and go ahead. Nice and light and easy. Good. And again, this is a move that's going to be particularly important with L4-5 disc problems. You're going to get a lot of radiating pain and cramping into this muscle. You're going to be doing a lot of TS and TL on this particular area. Good. And if we move into TS for gluteus medius, we're going to have you lie on your side with your right side up. This is a muscle we need to be strengthening. We could actually check this muscle again on Max, seeing as it's the only muscle, and it's a particularly important muscle for him for the hip stabilization when he's lifting. And he recognizes that as well, so he wants to get it strengthened up today, right? Yep. For all this time you've been spending with us. Okay, here we go. You're going to come down, and it was the anterior fibers. So if it's the anterior fibers, just depends upon where the leg goes, okay? The knee is going to come down. You're going to do some adduction. If it's the anterior fibers, the foot is going to also come down. If it's the posterior fibers, the foot is going to stay up, and if anything, maybe go up a little bit further. So we're doing anterior fibers, which means, Max, you're going to come down, and the foot's going to follow its way down. So if you can't see that on the camera, come down. I may turn him over in a minute just to show you. Breathing in, coming down, easy, easy, easy. Feel it relax under my finger, Max. Just, I've got your leg, let me have it. Very important, breathing in to have the patient, that's it. Come down and bring the foot down. And one more time, breathing and come down. I can feel that in there. Yeah, you definitely needed that there. Let's just check it quickly. And just, now we'll hold this here and turn it in a bit. Now he's strong, he's very, very strong. Let me just show you that one more time over on the other side, even though it's the left side. Let me show you the positioning of this move. For the anterior fibers, he's coming down, and the leg is following its way down this way. For posterior fibers, the leg comes down and the foot goes up. And there you have glute medius and minimus TS. All right, right, we've got sartorius, that great muscle that crosses your legs. So here we have it here. We're in that position of leg crossing. Hold it like that. I'm going to push this way and pull down this way. And hard as a rock. Okay, for sartorius TS, we're going to be in here. We're going to come in, and we can even start at the origin, which is the anterior superior iliac spine. We can start at the origin, breathing in, and what he's going to do is he's going to turn his leg this way and come down very much like psoas, breathing in, and go ahead. And he just keeps inwardly turning the leg more. And then with sartorius, we can actually use the turning of his leg here to hook the muscle and allow our PDM to come down through that very long muscle. See that? His leg, and the direction of his leg as I'm hooked, actually enables me, breathing in, to do a very, very effective PDM, because he actually pulls my contact down into the muscle in a transverse direction as he rotates his leg. Max had to go to training. He's on a heavy schedule. If you want to see more of him, you can see him on the show that we did, the Dr. Don show, which is a fabulous introduction to trigenics for your patients. Now we have Sarah, who's here to help us out. And Sarah's going to lie down on her back. We're going to get started on quadriceps. We're going to do our strength testing for quadriceps. I'm going to put this leg down. We're going to bring this leg up. And a couple of different ways of doing it. Here's one way for rectus femoris. She's going to hold it up. The other way for rectus femoris is positioning yourself so that you've got some leverage and pushing down. Intermedius, you can use your knee or use your arm, whichever you want. For me, I like to use my knee. Hold it there. There's your intermedius. So we're on to rectus femoris TS, a very simple procedure. We're going to contact underneath the anterior inferior iliac spine at the insertion. Don't forget the rectus femoris also goes up and has a slip into the posterior superior rim of the acetabulum, which is an important thing to remember. We're going to come down this way very, very lightly, and I've got my thumb now. Most important, bring it all the way back, compress completely, and just almost get your thumb right under that bone. Breathing in and coming down. Very nice. And again, breathing, coming down. Now, for this procedure, this is pretty much up at the origin. Breathing in and down. And there's your TS. Now that was the origin for the middle part of rectus femoris. You're going to put the patient's ankle up on your thigh, and you're going to have her lightly engage the hamstrings by pressing her ankle down very, very, ever so lightly to allow for passive flexion of the knee. And at the same time, you're going to use an S PDM on the mid muscle. Breathing in, and go ahead. Very nice. Okay, I'm going to show you over here what that PDM looks like, even though it should be done over here. I'm going to show you for the sake of the camera. That's what it looks like. There it is there, if you want to zoom in on that. So you're going to get a real S like that. Now, one of the things you want to remember is you need to be able to have her so that you can actually apply some traction here like this without, because this is where you're going to have your resistance in here. So you've got her actually in between your side and your thigh. You've got her hooked in there. Breathing in, and go ahead, slow. Good. And again, and go. Perfect. Now you can also use double finger contact. This is an important procedure. You're going to use it with a lot of your athletes, that's for sure. And with the double finger contact, this way you're going to go lateral to medial. Breathe. Keep coming. Oh, you've got a beautiful myonural reduction on that one. Good. Okay, and so now we're going to do an infrapatellar TS. We're going to start on the lateral part of the patellar tendon. We're going to move into the medial part. The patella usually subluxates laterally. This is going to help to relocate it medially. And don't forget to always do this procedure in conjunction with the popliteus TS procedure. She's going to do the same thing basically she did with the other leg. She's going to actually press down very lightly on the heel this way. And as she does so, the knee is going to passively flex. She's not going to actively engage the quadriceps at all. She's just going to lightly press down this way. With this one, we're going to apply a little more traction, breathing in. And here we go. That's good. A little bit more, a little bit more. Let's press down with the heel a little more for me. A little more with the heel. A little more with the heel. And let it go. Breathing, you're going to come right underneath. You may even want to hook your thumbs together, breathing. And again, press down with the heel a little more. And that's it. There it goes. Now it actually started to move as she started to engage the hamstrings a little bit more and press down a little harder on the heel. I could feel the patella actually moving and feel a myoneural reduction in the infrapatellar tendon. Quadriceps TL, prone. We're going to have the patient, I should show you the PDM on that. You're going to come in this way, and you're going to go from medial to lateral or lateral to medial, whichever is better for you. You can also do it an S procedure this way or this way. Breathing and straightening fairly hard. And let it drop, let it go. Breathing, you can see how much farther that's coming down, and straightening. And letting it drop. Very nice. She's getting a lot more in there. If you want to add a little bit to it, you can also elevate the leg. Breathing. And let it drop. Very nice. Okay, for vastus medialis, we're going to do this procedure from my office. What we're going to do is we're going to start seated in between the legs of the patient, and you're going to use a hook-like application here, which is very powerful. You can use either your fingertips for the PDM, or you can use the heel palm, which is also very powerful, and you'll feel it in there. What you're doing is you're leveraging, increasing your amount of leverage in this direction for your PDM by pulling on the opposite hand. And when you do that, and you also press in with the leg using the upper arm as a lever against the lower leg, like this, then you increase the amount of PDM that you're able to apply. Okay, so that's why I'm wrapping my hand around here. I'm actually bringing this arm around and using the leg as a lever. Okay, now when you do the procedure, what the patient is going to do you're going to ask the patient to contract the hamstring a little bit and the external rotators. So basically what's going to happen is this heel is going to come in this way and the foot's going to turn out that way. So the heel is going to come in lightly this way, very lightly, causing the knee to passively flex, and the foot's going to turn out. And as she does that movement, I'll be able to apply the PDM. And what I'm doing is I'm resisting. Sometimes, it depends upon how long your arm is, I can resist this external foot rotation with my arm here. Okay? So if I wrap it down low enough, I can resist it. The only problem is some of you may not be your arms or body parts may not be long enough to be able to do that. If that's the case, then don't worry about resisting the external foot rotation. Just have them actively externally rotate the foot, but make sure that you get your force in here, or if you really want to get the external rotation, then you'll just use one hand from here. So let me show you both of those moves. The first one, where I'm using the leverage grip, she's going to breathe in. As you breathe out, she's coming up. And what we're getting here is a beautiful unloading of that vastus medialis, breathing in. And I can come right in on it, and that's just where that little knot usually is. Very nice. You can see how we're distorting the fibers, breathing in. And again, this is a beautiful move because as she actually moves her leg, all I have to do is hold my position, and she will bring my PDM into a transverse application by itself, breathing in. As she moves, you see, I just maintain the pressure and it actually moves into the fibers of vastus medialis.